Welcome to Reducing the Pucker Factor podcast, presented by the Blakery Content, the show to make every EMS and critical care provider feel sharper, calmer, and more prepared when the pressure is high and the patient is small. Here, we're going to dive into real conversations that matter: pediatric readiness, high stakes, decision-making, pre-hospital innovation, and the human side of caring for kids and families in their most vulnerable moments. From the scene to the sky, from the med unit to the helicopter, this is where EMS meets clarity, confidence, and community. Whether you're an EMT, paramedic, nurse, or flight clinician, our mission is simple: reduce the pucker factor. One practical insight, one expert guest, and one powerful story at a time. But before we get started, a quick reminder: the content in this podcast is for educational purpose only. Always follow your local protocols, policies, and procedures, and practice within the scope allowed by your state and your medical direction. Every system is different, every patient is unique, and your agency's guidelines always take priority. Now, take a deep breath. Let's get ready to turn that chaos into confidence. This is Reducing the Pucker Factor podcast. Let's get into it.
For the medics in the front line, let's go. For the flight teams on the lifeline, let's go. For the ones who are running faster, we're reducing the pucker factor. We're reducing the pucker factor, turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop. Yeah, we're the Blakery Content crew, leading what the pros now do. Turning fear into calm under pressure. Pucker factor, gone forever. Gone forever.
So let's go there. Why whole blood? Why now? And what should EMS providers be thinking with pediatric shock and hemorrhagic shock?
Well, listen, when you look at the data and you know that, pediatric trauma is like it's the leading cause of death, right? Especially as you get to the toddler age group, especially up into the teenager age group. Nothing special happens when you're 17 years old and 364 days. Nothing special happens tomorrow that makes you qualified now to get whole blood. Nothing. Okay. The people who push back against it, I ask them a very simple question. I said, okay, so you don't want us to give that blood in the EMS. What is that exact patient going to get when they enter through the double doors of that hospital? Oh, they're going to get blood. Okay, so wait a minute. So what magically happened once that patient crossed the threshold to allow you to now give the blood? And they don't have an answer for that. So the more you say things like blood belongs in EMS, TXA belongs in EMS, phaneothoracostomy belongs in EMS, right? The more you start to say that there are things that we do in the pre-hospital setting, plasma belongs in EMS. These are things that belong in the pre-hospital setting because the earlier you get them, the better off the patient is. And I know we may talk about antibiotics for sepsis too. These are all things that have been told to us that should only happen at the hospital. Why? And this is maybe, now I'm thinking how I may have answered one of the first rapid fire questions incorrectly, which is that they have never valued EMS, right? And I think I did allude to it a little bit, but the fact that the House of Medicine thinks that medical care starts at the hospital doors is one of the biggest fallacies that exist today. Once they bring in EMS and they say, you're not only you part of the continuum, but you're effectively the most important part of the continuum, then it's of course you should have whole blood. Of course you should have plasma. Of course you should be doing double sequential. Of course you should be doing phaneothoracostomy. Of course you should be giving antibiotics for sepsis. It makes 100% perfect sense. So, but I'll tell you now that on the other end of it, you're not going to see that many pediatric trauma calls with massive hemorrhage, just like you're not going to see that many pediatric cardiac arrests. And therein lies the problem. Across the United States, every year, 350,000 adults go into cardiac arrest. 150,000 of those actually get worked on by EMS. The other 200,000 are just dead when we get there. So when you look at those numbers, it's a lot. It's a lot of people, right? But then when you look at the pediatric numbers across the country, the numbers are quite small for true cardiac arrest. It's in the low thousands, right? We used to have numbers of 20,000, but you look at the CARES data set from 2024. I don't have the exact number in front of me, but it's something like 3,000 cardiac arrests that were worked.
Okay.
What that means, if you divide that number by the amount of EMS systems there are across this country, then that means that every EMS system, and especially the rural ones, are going to have 0, maybe 1, right?
Yep.
0, maybe 1, 0. So when you talk to your friends, they say, "Oh, it's only 0 or 1." And you go to the larger agencies, maybe it's a dozen. It's not a lot, right? Because in Palm
Yeah.
Beach County, we do 60 adult arrests a month, right?
Wow.
So having 12 a year is only 1 a month. It's like nobody notices. So I guess the point I'm trying to get to here is that when people don't see it as a problem because they're only looking very myopically at their own region, at their own city, just like pediatric stroke, oh, it's not a problem. Oh, yes, it is when you aggregate them all. So when you start to aggregate and you can say, okay, of the, let's say, 3,500 cardiac arrests, if we can make an improvement of 10%, right, that's 350 children. In trauma, not traumatic arrest, but in massive hemorrhage, we're having outcomes of 90% survival, right? So if you could double survival from traumatic hemorrhage, where you see a whole lot more of traumatic hemorrhage than cardiac arrest, well, on the aggregate, you could be saving hundreds and hundreds of lives. So that's really what I think people have to get to overcome, is to not say this doesn't happen. Well, it does happen. And if you have the resource on your trucks anyway for the adults, it is unethical and immoral and inappropriate to withhold it from children. And there are people out there who are fiercely fighting that EMS should not give kids blood until it's their kid, right?
Right.
The only reason that the United States has pool drain laws that are so rigorous is because James Baker, legendary former Secretary of State, etc., his granddaughter died because she got stuck to a drain. So what I'll tell you is that in the future, when we're already 6 feet under, every kid's going to get blood in the field. Not every system, but every region will have whole blood and plasma. They will. It's obvious.
Yeah.
I mean, if people don't see that now, then they're just lying to themselves. The question is, how hard will we push today so that the next agency who's coming online in a month from now doesn't leave out the kids? That's what they're doing. They're going to say, no, we'll start with the adults and then we'll come back around. You know what come back around means? It means 3 or 4 years from now, we'll finally do it. And in that community, 4, 5, 6 kids have died, right? So that's why I'm so passionate about it. There's no one who can give any solid argument. There's nobody who can give an argument. And all the people who are against it, they're sitting behind a keyboard. They won't come face to face because they're just saying stuff that just is not true. The data supports pediatric whole blood in the pre-hospital setting just as it does in the hospital setting. So it's pretty obvious.
Yeah.
And we got to make a move to do it.
Yeah, absolutely. I agree with that completely. And again, I'm very fortunate in the region that I work in. Most of the things that you had mentioned, we are doing. So we have pre-hospital blood in this area.
Good.
It's been added to, initiation of blood products has been added to the paramedic scope of practice. We recently added finger thoracostomy to the paramedic scope of practice. TXA has been in there. So I feel very fortunate, but it's interesting traveling around to these conferences and things where people are still talking about it to where they're not doing it. And I feel like, I've been fortunate enough to go to quite a few conferences lately, and I often leave them thinking like, I'm not sure I got much out of this because they're talking about things like, why are we still talking about these things? Like, these are things that we've been talking about for years. Why are we not implementing them? And like, so what do you think is one of those biggest hurdles that's preventing us from getting that up and moving and more people doing it?
Yeah, that's a good question. I think there's a couple structural things that need to be spoken about. One is that I live in Florida. We're a delegated practice state. That means that I could do whatever I can convince my agency to do, we can do, right?
Mhm.
However, if you live in a different state where you have state protocols, well, now the board has to then agree to doing something like blood. And there are great states, like, for example, in Colorado, there's a guy named Scott Branney, ex-military guy, brilliant. And he says, I'm going to put this blood thing on my shoulders. And he knows he has that political jujitsu, and he knew how to run a process, bring
Yeah.
stakeholders to the table, start to build a rapport with everybody. He gave them all the data, brought to them all the science, created the protocols, got buy-in from all parts of the state. And then the entire state said, okay, now we're good. Now we're going to go ahead and allow anyone who wants to do this to go ahead and adopt it. So that's a very thoughtful way of doing things. And so if you have a very well-run state EMS office, like we do in Florida, they're just amazing human beings up there, then you're in luck. However, if you're not in a state like that, and you're basically a very if you're a high-performing EMS system with a low-performing state, then now you basically have to start to ask for revisions and whatever they call these things, where they got to ask for permission to please, please, please let me do this. So that's kind
Yeah.
of like the state level stuff, I would say. At the individual department level, so you would say, okay, Pete, based on that theory, everybody in Florida should be using whole blood, and they're not, right? We have about 13 agencies only currently today out of the 360 something agencies. Why? Inertia, right? So I would say that people in EMS do things when they have a certain number of inputs that become green. Okay, so for example, um, and now I'm talking from the leadership EMS level. There's two big things that an EMS leader needs to have or know of before they do something. Is this going to make me look bad? Because if the answer is yes, I ain't doing it. So how do they mitigate that risk of is it going to make me look bad? Well, they go to their buddies who have done it already. And now their buddies are looking
Yeah.
like heroes, right? You go to any of the chiefs who are doing whole blood, they walk around with like the chest puffed out, like we're doing. So now those chiefs are like, it's not it's going to make me look bad, but it's going to make me look really good. And I'm behind the eight ball. I'm going to do it. The
Yeah.
second part is how much work do I have to do to get this thing done? That's where they stall, right? Because they got to go and you got to buy the equipment, you got to get the education. There's a whole CQI. You have to do all the logistics. You have to know how to work the coolers and and then you got to go get it paid for. So now the
Yeah.
chief's got to go to the city council and say, we're under budget and we're losing money, but I can't even pay my own people and their pensions aren't that good and their salaries aren't that good, but I need
Yeah.
40 grand to start a whole blood program. So, and unfortunately, when you're in a position where you're going to be retiring in 2 to 3 years from now, there are people who just going to say, "Listen, I'm in this seat. I'm retiring in 2 to 3 years. It's not something I'm going to take up at this point in time." And the last thing I'll say, what's going to end up happening though is if someone's listening to this today who is a city commissioner, town council person, they're going to be the ones knocking on the door of the chief and saying, why don't we have whole blood? I heard that Davie and Broward Sheriff's Office in Palm Beach County and Palm Beach Gardens, we're sitting here in our town. Why don't we have that resource available to us? Once that happens, which is going to happen very soon, it's happening already, but once that starts to happen in a very serious way, it's going to be a tsunami. And the problem is those people at that time aren't going to have the right people, the know-how, because you have to start prepping for this occasion in advance. It's
Yeah.
almost like having a wedding, right? You don't wake up one morning and say, everyone's invited, come on, we're having, no, you spend 6 to 9 months preparing for the big day. Whole blood is like a wedding, and it costs as
Yeah.
much money, right? So I
Yeah.
think that's what people really have to think through it. Start to think through it now, even though you don't have the money for it. Start to think through it now, even though it may not happen for a year. You need to start today for when that event does happen in a year from now. And that's what we're doing in Florida, across the state.
Yeah.
We are now getting ready to do a whole blood program for everybody across the state, funded by the state. So it's going to be wonderful. But we're starting now to get, to start planting the seeds so people start to recognize their turn is coming. We want them to be ready when that day does come.
Yeah, absolutely. And so for an organization I previously worked with, I hit those challenges and roadblocks when I was trying to push out stop the bleed kits. And it just came down to the logistics and funding and education and all this stuff. And so what I just started doing was every time there was a hospital or organization that was involved that had an incident that occurred, I would just send them off. And the news thing of like, they weren't prepared for this, or what were their preparation things. And it's just like it is now at the point where and you know this personally, it gets to the point where it is, when is it going to happen, not if it's going to happen. And we have to be prepared and take those situations on, and kind of jump through some of those hurdles to make sure that we are in the best place, so that at the end of the day we can stand up and say, we did everything that we could because we were prepared. And it goes back to the pediatric readiness thing and all that. It's just shifting a mindset of going from the responsive side of responding to something versus being prepared for something, and taking it on that way. So
It's leadership. It comes down to
yeah.
leadership. Everything you're talking about comes down to leadership and the willingness to do what's right. And the beauty of
Yeah.
EMS, for the most part, is that everybody who's in EMS, we are there for the social good of the people, right? We're not
Yeah.
profiting. EMS doesn't profit from the community. It's a tax-based thing, right? So if you have X amount of dollars given to you by the city to do something, why wouldn't you maximize those dollars, put those dollars to use in a way that you could have a recognizable benefit? And that benefit is, and we just had it at Palm Beach County where we had people walking across the stage that would have been dead. And who's in the
Yeah.
audience? All the commissioners, right? And what are we
Yeah.
saying? Thank you, Palm Beach County, for believing in us, to giving the chief the money so that we can then do this and look at the output, look at the outcome,
Yeah.
right? So again, there's a lot of pre-gaming involved. There's a lot of, work that goes into making big change happen. But once you know the steps to making big change, you can just use those steps over and over again and do big change type things.
Right.
And so there is a method to the madness. Yeah.
Yeah. So let's transition to the clinical side of that a little bit and just speak to, so what are the indications for giving whole blood, and what are the desirable outcomes? Like why is that the benefit, or the go-to treatment that we should be doing versus the standard of care that's occurring currently?
Yeah, that's a great question. And actually, I'm part of a group now that is, um, we're going through like a Delphi process. And all that means is you get a bunch of quote unquote experts, and you ask them a bunch of questions about what they think a clinical protocol should look like, even down to the terminology, right? So should we call it suspected hemorrhage or any patient with suspected massive hemorrhage? Like, we're going down to the nitty-gritty detail. What I would say is that, um, there are many protocols out there, and my protocols are freely available, and I've given my protocols away to hundreds and hundreds of people. So if people are listening to this, again, you could put my protocols in the show notes as you wish. But basically, it's medical or traumatic massive hemorrhage, enough to cause vital sign abnormality. And once you hit certain criteria, which is age-based in children, in adults, we have a qualification for people who are on beta blockers, right? So we actually make it easier to give it to the geriatric patient because we know that A, they're at higher risk. B, they're oftentimes on medication that don't allow their heart rate to go up. So I think you have to be thoughtful about what those vital sign criteria are. We use a surrogate for hemorrhage, which is a low lactate. Sorry, I shouldn't have said that. A low end tidal CO2. And it makes sense. If you have your entire blood volume reduced by half, well, the amount of blood returning to your lung is returned by half, and therefore the amount of end tidal CO2 exiting your lung will decrease. And so it's been shown in the data that an end tidal of less than 25 in a patient with suspected hemorrhage is massive hemorrhage, enough to get blood. Just like in septic patients, an end tidal of less than 25 is a surrogate for metabolic acidosis, right? Because you have a respiratory alkalosis to compete or to actually help the metabolic acidosis. So the end tidal of less than 25 in a septic patient, for a completely different reason, shows you that the patient is septic. But specifically, the end tidal for hemorrhage is because you're missing a lot of your blood volume, right? So we have that as a criteria. And we also have the shock index as a big number. So everyone's blood pressure, let's assume systolic. Let's start with the heart rate. Let's assume your heart rate is 60 and your systolic blood pressure is 120. 60 divided by 120 is 0.5. That's a normal shock index. Once your heart rate and your blood pressure are the same, right? 100 heart rate, 100 systolic, 100 over 100, shock index is 1. Once you're 1 and over, your odds of mortality start going up and up and up. So 1.1, 1.2, 1.3, 1.4. Once you're at 1.4, your mortality is now 40%. So we use shock index as well. The only thing I worry about, Christopher, if I'm being honest, is that if your protocol is too lenient, think about what happens. Then everybody gets blood, and it looks like everybody lives, right? So I would say that you have to have almost like real-time CQI here, especially if you're starting a blood program, to make sure that you're giving blood to the people who are benefiting from the blood. And the reason to do that is because if you start giving blood to the people who didn't need it, the people at the hospital are going to get very upset with you, and they're going to start slamming you.
Right.
And oh, by the way, they will do that anyway, because these patients get so much better so quickly that they don't believe that the patient was unconscious and bradycardic down to 30 just 10 minutes ago.
Yeah.
So you have to have a solid protocol. You have to document everything very well and prove that, why you gave the blood. Having said all that, you have to have a paramedic discretion because you know it, because you're a great, clinician. I have amazing clinicians, and they know what death looks like or what death is going to look like when a person is diaphoretic, looking pale, but they're compensating so well because they're healthy, young adults, right? They're not the older person, that their vital signs are still hanging in there just enough, but you know that they're bleeding out because of the mechanism of injury and their current vital signs that haven't hit the threshold yet. You need to allow paramedic judgment in for blood or plasma. So yeah.
Yeah, and so that's one of the teaching points that I speak to often when I'm talking about shock and hemodynamics is that, we've been told forever that kids compensate and compensate and compensate till they don't, and that there's this imaginary cliff that they fall off of, and once they fall off that cliff, it's hard to get back. And I always say, I don't dispute that, but what I would argue is that there was signs leading up to that the whole way that we're missing. Right?
Oh yeah. Oh, yeah.
Kids compensate so well that they look well until they're not. But if you're looking for those subtle changes, then you're going to pick up on that sooner. And those are the kids that we can actually intervene on early, resuscitate early, and have a huge impact on their outcome.
I mean, you couldn't have said it better. I mean, that's exactly right. And turns out that kids do better from pediatric trauma than adults do. This whole concept of, oh, kids do worse. No, they don't. They have better vessels, they have better compensatory mechanisms. You give them blood, they will bounce right back, right? So, but it is, and I've missed exactly what you're talking about. I mean, I don't want to embarrass myself, but I will. That I have missed sepsis way more times than I want to admit to, because I've been doing this for 25 years now, 26 years, and we've all had that patient where like, oh, they look good. All the other patients in here have fevers, and but that one, how did I miss that? The mom came running out saying, "My kid looks pale and not conscious." Yeah, I screwed that one up big time. But when I go back and I look at the soft blood pressure that I just ignored, or the tachycardia, and I attribute it to the kid was crying when I was in the room, I learned how to fix that. I told the nurse, attach the leads, close the light, close the curtains, and I'm gonna go out there and watch this monitor. And I watch the heart rate either stay the same for the next 5, 10, 15 minutes, or after I left, then the kid's heart rate, after they stopped screaming, came down. The recognition of sepsis, the recognition of oftentimes occult hemorrhage, just like the recognition of sepsis, is very difficult. And I think that's a skill that you have to um, really refine over time. And if there's anything that is a certain muscle, and going back to your paramedic program where they have a lot of exposure to kids, that's what that exposure does. It allows you to build that muscle where you say, I need to really sit there and observe this kid. And I would find myself for years as I got more mature in my career and a little bit better clinically, I would just walk into the room, sit on the stool, kid sick, sickish. I'm trying to figure out. And I would just sit there, talk to the mom, making small talk, and I'm looking, and I'm just trying to figure out. I'm looking for a blank stare. I'm looking for a furrow in the brow. I'm looking for things, and I'm just absorbing all of that, just looking right at that kid. And I still missed. I still, even doing after doing all that, you still miss, but you really have to be attuned to the fact that when the kid's dirt sick, it's easy. When the kid's super well, that's easy. It's the kids who are in the middle that you really have to spend time and kind of being present, and that's how you figure out what's going on.
Yeah, so I would do the clinical orientation for all these students that were coming to the pediatric hospital, and I would always tell them, like, listen, and I set it up the program so that they spent time in the ED with a nurse, they spent time in the ED with the PEM attending, and then they would go to the burn center, they would go to the step down unit, where all, like, the trach vent kids were with a respiratory therapist, and then they spent time in the PICU and time in the NICU. So they got to go to all these facets, and I said, I don't want you to go in and think like skills wise, like I have to do X amount of skills or do this and that. I said, I just want you to get exposure to these kiddos and see what they look like, and be able to make that differentiation between sick and not sick and pick up on those subtlety things. Cause a lot of these are 20-year-olds that don't have kids or aren't familiar. And like one of the things we would send them to do is the feeder and grower unit in the NICU and just hold a baby and feed a baby that wasn't ill
Uh-huh,
appearing
uh-huh,
and just see what that
uh-huh.
looked like, and then go to the higher level NICU and see those preemies that were intubated and hands-off care and all that stuff, and just to get them exposure to see what that world looks like.
Yeah. Yeah. That's so smart. And I wish that more programs did what you're doing. It's all about the reps. It's all about the
Yeah.
reps. And I think that um and I'll be honest with you, there's a friend of mine, David Spiro, who started a company called Real DX, REELDX. And what did he do? He's a PEM doc, super smart guy, so humble. But he's very present with his patients and with everybody. When he talks to you, you kind of feel like you're connected to him. And he said, "How am I going to give this exposure to all these people, all these students?" So what he did was he started to get consent, and he just started recording. So he has hundreds and hundreds and hundreds of videos, and now medical schools and a lot of schools use his content, and you can get a lot out of video nowadays.
Yeah.
Where a lot of people FaceTime me for their children, and hey, and it happened the other day. Someone sent me a video of a kid in the emergency department, and in 2 seconds, I said that kid's grunting,
Yeah.
and it turned out that kid had inhaled something that ended up causing him to have some oropharyngeal swelling, and I said, tell them to give him Decadron and racemic epi because that's what he needs.
Mhm.
But he was in a place where they weren't recognizing any of that. They just saw a panicked mother.
Yeah.
So it was good. I think videos can be used to train people on pediatric assessment. I'm a firm believer in that. Say that if people want, now I'm remembering, we actually did 13 episodes of what we call Real Emergency, REEL Emergency on YouTube, and we
Okay.
used David's content. So if people go back and look at those episodes, I think 4 or 5 of the episodes we used video content from. I mean, they all have video content. That's the whole concept of the 13 episodes were. But I
Yeah.
think 5 of them were great pediatric cases from David's content. So just a plug for David.
Um,
Yeah.
yeah, I'm definitely gonna go check that out. That's fantastic. So I was going to say, just to transition here one more time before I run out of time with you here, but really, as we kind of talked about all that, the way you talk about the trauma assessment and resuscitation, it really always just comes back to that one theme of clarity under pressure, and obviously that philosophy is going to show up in the other area that we've been discussing briefly, and that you've been pushing really hard, is pediatric sepsis. And I mentioned this earlier, but for years you felt that EMS shouldn't just assist in that early sepsis care, but they should truly own it and not wait for the hospital, not hope that the signs are obvious, but recognize it, act on it, and kind of set that trajectory before that child ever even sees a physician. So, in the last bit here, let's kind of get into that. And why do you believe that EMS should be leading the charge on pediatric sepsis, and what does that actually look like in the field?
Yeah. So this is a story I've never told before, but it's got somewhat of a good ending. But it was a child who really impacted me. He was 10 years old. Sepsis was missed by his doctors, his pediatrician, twice. By the time the kid came into me, he was floridly septic. Like this kid, the fact that he's alive today is really a miracle from God. And um, we ended up giving him everything, like the kitchen sink, intubating him, multiple antibiotics, but he needed so many pressors that he ended up losing all of his limbs. He's got, um, it was above the elbow bilateral and below the knee bilaterally. Okay. This kid's in college today, and he's, he's, he's just a miracle, right? Perfectly normally, like he's with it. So super smart.
Wow.
And that patient really impacted me, and because I knew that if he was diagnosed a little earlier, if he was given antibiotics a little earlier, if he was giving fluids a little earlier, if he was giving pressors a little earlier, he would have all of his arms and legs, right? And that's just the one case, but I've been involved in many, 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 many other really bad sepsis cases, not just for pediatrics, but now for adults.
Right.
And for the last 7 years, I've had programs now, not programs, my agencies have been giving antibiotics in the field, 7 years. We just published in September, last September, our paper, 1,308 patients in 1 year that got antibiotics for sepsis.
Wow.
And we just submitted our abstract to NMSP that the mortality rate of those patients was only 7%. By the way, average mortality of floridly septic shock patients is 20 to 40%. So if you just look at the numbers, anyone listening today, we've talked today about cardiac arrest, we've talked about trauma. When you look at your sepsis numbers across the board, adults and kids, it far exceeds any of the other things that you'll do. And the problem is that many people don't see the death because that 80-year-old who's at the sniff, who is septic when you got them, but they didn't get antibiotic for 2 to 3 hours until they got to the emergency department. You may not know this, but that patient's dead in 2 days from now. You won't know that because they're not going to call you. You won't see the death because it happens in the ICU. After they fill the patient with fluids, they get ARDS, they're on a ventilator, they pop some pneumos, and then they're dead because they're 80 and they're not well. So the fact that we could be detecting sepsis early, the fact that we can be giving them fluids, we can be giving them pressors, we can be giving them antibiotics, and we can do it hours before they would have received it otherwise, and bring the mortality rate and cut it in half. Why wouldn't we be doing that? Why wouldn't we be doing that? Why wouldn't we be doing it for kids? Why wouldn't we be doing it for the adults? Especially if you live out there in the rural area where the patient's not going to get antibiotics for many hours.
Yeah.
To that extent, there's a study in Canada that just finished enrollment called the Pit Stop study. Pit Stop is looking at antibiotics for sepsis in adults, randomized controlled trial, and they're also looking at standard fluids or a lot of fluids, like 1,500 to 2 liters, okay, early. That paper is going to get published in the first quarter, so early 2026. Now, I don't know the data. I know they submitted their pilot, their early data, which was striking in favor of antibiotics and fluids. So I will bet the farm. I don't own a farm, but I'm going to bet the farm on the fact that antibiotics and fluids for sepsis magically is better for patients in EMS, right? Yeah. So this is just another thing that we're going to watch evolve over the next 10 years, where when we have a lot more gray hair and we're back on this podcast in 10 years from now, you and I are going to be talking about how still 50% of EMS systems are not giving antibiotics for sepsis. Just like 3 years after the double sequential study, the dual sequential study showed you can double survival from people who are dead and you can make them undead, double neurointact survival. Yeah. Still very few people 3 years later are doing dual sequential. It's like there's like 20 things, many of we haven't even talked about today, that are happening today in healthcare that are completely wrong, that are completely off base, that we should do today, that there's data on today that we're still not doing. And so as I sit here talking to you about perhaps why aren't people doing those things, it comes down to, I think, a few things. Number one is that EMS needs to take itself more seriously and rise above. The rest of the house of medicine has to take us more seriously. And we just have to keep showing the world that EMS belongs, that we exist, and that we are of great benefit to the sickest patients, from trauma to cardiac arrest to sepsis to stroke. EMS is the first link in the chain. And I'm going to keep screaming from the mountaintops until someone comes and kidnaps me and puts me in a cage.
Yeah. So a couple things there is what I think of when you said, EMS needs to step up, right? So I think one of the questions I have is, what do you how do you motivate the agencies that think, well, I'm only 5 minutes away, I'm only 8 minutes away, 15 minutes away from the hospital? How do we motivate them? And you can include in that response, these same agencies are the ones that are still transporting full arrest patients. They're not staying on scene and doing that, the 20 minutes or field term or what have you. So like, how do you shift those mindsets and agents that that's the culture of the agency and make them understand that just because you get them through that threshold of the door, right? Like I think you alluded to, the hospitals think that that care starts once they come through those doors, but how do we also get EMS to understand that there's a lot of care that can be
Yeah.
done, and just because they hit those hospital doors doesn't mean that care starts right then. It delays, time to
Yeah.
first dose epi or time to first antibiotic or first pain management. It's all delayed. It doesn't happen immediately as they go through those doors. So I know that's kind of a big couple questions there, but
No, I'll tell you. So I have the answer. Ready?
okay.
And I should write a book. I should write a book on this. But there is a playbook to making this and all the other types of change that we talked about today. And I'm gonna give it to people right now. I've been using this
I'm
playbook for a long
I'm
time.
sitting up. I'm ready for
Okay,
this
here we
one.
go. Okay, here we go. Okay, so the first step is to go ahead and look at your own data. So let's take a look at the sepsis patient. Go look at the number of sepsis patients you transported last year. Take the last 12 months. Go look at the time they called 911, the time you arrived on scene, and the time that you transferred them into the care of the emergency department. Then you go to the hospital and say, hey, hospital, I have a little spreadsheet here, and I'm willing to share my spreadsheet. I'll just give you not my patient data. I'll give you the headers. And the headers say, for example, what time, hospital, did you give your first bolus? What time did you give the antibiotics? Did you do a lactate? Was their blood culture done? What was the patient's outcome? What was their ultimate discharge disposition? Did they go to the ICU? Were they ventilated? How many days were on the ventilator? Okay, so you can collect, and again, there's really 5 data points that you need. I just gave you a lot more than that, but you
Mhm.
take your 20 patients, you ask the hospital for those data points. Okay, now you have your mortality rate. It's a small one, but if those 20 patients, 10 of them are dead, that's 50% mortality. And now when you walk into the meeting, you can say, hey guys, I think we have a problem here. Their averages of 20 to 40%. There's a paper that says Palm Beach County only had 7%. And this new pit stop randomized control trial shows only 6%. We're way off base here. Okay, so now you have your local proof. That's step number 1. Step number 2, bring in an expert. And nowadays with Zoom, you can do that. So I recommend that if you're trying to make a big change, for example, this thing about the C collar may be more harmful than good, right? What did I do? 2 weeks ago, I brought to my webinar the guy who wrote the paper, and he made a very convincing argument. So now instead of Peter Antevy going and saying, I think the C collar is more harmful, I just send them this webinar, and people are like, oh my God, this guy, I think he's right. Okay, so people who are out there who are big agency, small agency, they should reach out to people like you, people like me, Sheldon Chesky's, and say, hey, would you mind doing a 30-minute presentation for my team? I'm trying to get sepsis, antibiotics for sepsis. They're telling me that the hospital needs cultures and blah, 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 blah. And then I'll come on and I'll debunk all the myths. I'll show them all the data. And then, so that's step number 2. Houston, we have a problem with step number 1. We now hear it from the expert that they got in here who had a pretty convincing argument. Okay, that's step number 2. The third thing is now you bring in a group of stakeholders. What does that mean? You send out an email. Hey guys, I've been doing a lot of research on the sepsis, the antibiotics for sepsis. We did a local study. We found our 50% mortality rate. We just had a webinar with Dr. Antevy about it. And my next step is I want to bring in all the stakeholders, the infectious disease doc, the ER doc, the EMS medical director, the whoever, and we're all going to have a Zoom next week to talk about this. And on that Zoom, everybody has a voice, and you start to hear what this person's objection is and that person's objection is. And then you start to go and you start to work through those objections, right? And then there's going to come a point where now everyone is on the same page. And if you've done a good enough job in presenting everything, you now have the Sepsis Coalition, and you're now collecting more data. And now everyone's talking about sepsis. And then finally, you can say, now, what I would recommend is that we try this solution. We have a solution here. It's been used at 25 other departments. It was a randomized controlled trial, the exact same protocol that they're using. I propose that we use it, and now we'll do a before and after. So can you give me a year? Give me 1 year of using Rocephin or Cefepime here at our agency. And if after a year we see zero difference, I'm done. I'm gone. Okay, pilot, data, you're going to publish it. I'm in, because now you're showing me what I was. You've proven to me by experts. We got the stakeholders, so all the hospitals now understand what we're doing. There are blood culture bottles that they can purchase for $1 extra that are antibiotic eluting, meaning that they'll soak up the antibiotic that you just gave. You could point them to 2 or 3 studies that show that if you take that blood culture within 15 minutes, it's basically not going to impact the cultures pretty much at all, if not just maybe a few percentage points. Slowly but surely you build a case, and then you come in for the ask, which is, give me a year, we're going to pilot this, and I'm going to give you more data. So that is basically the playbook. That doesn't take, and so we've done that for cardiac arrest, high performance CPR. We've done it for pediatrics. We've done it here for stroke. We're doing it for whole blood. Everything I just told you about, we use the same playbook. Plasma for TBI. How did I get that done? I had John Holcomb do a 1-hour webinar. It's on the YouTube channel, Florida NEMSP YouTube channel. And everyone who calls me and says, who the hell would do plasma for TBI? I said, do me a favor, watch this webinar. They call me back. They're like, holy shit. He's been working on that for about 18 years. Yes. There's adult trials. Yes. There's a randomized control trial happening right now in Chicago. Yes. There's no safety issues. Yes. Okay. So let's do it. So we're doing that now. We already have 50 patients enrolled. We're already showing a benefit. Okay. We submitted our abstract to NEMSP. We're doing all the steps that we promised to be good stewards of the product, to be scientists, to do it in a way that is not based on anything that's fake, right? So we have 18 years of plasma for TBI data that no one's ever been talking about. And we said, based on all of this data and the world's experts, and the fact that they give plasma in every neuro ICU in this country, right? And in every burn unit in this country, they're getting plasma for burns. So we're not doing any testing on people that's inappropriate. We're basing it on factual science. We did the same thing for ketamine for seizure. How the heck did we give ketamine for refractory seizure and show about a 90% success rate? Because there's about 30 years of ketamine for seizure data, except they were all getting it on day 5, 6, 7 of in the ICU. We just brought it to EMS, and now there are people now who took our study. They're doing randomized controlled trials in Egypt. They're doing it here in the United States. So that's how science happens. You have the innovators who pilot things. Now, if you don't want to be part of that, talk to us in end of 2026, 2027, when 30, 40, 50, 100 EMS systems are doing antibiotics, 1,000, and then you're going to get the people who are in the bell curve, middle of the bell curve, and then in 10 years from now, finally it'll be in the guidelines. EMS.
Yeah, I think that's great information, and like you said, the stepping stone path. I think it goes back to what I said earlier about it's the approach, how you approach something. When you're showing up and you're giving you're not just complaining and saying, here's the issue, right? You're showing up, you're identifying the problem, and you're giving data and you've done all the legwork, you've done all the work up front and take that workload off, I think it makes it a lot easier to move forward with those processes. And those people that can make those decisions are a lot more inclined to move forward if they don't have to do, if it doesn't create a lot more work for them. If you've already offloaded all that, they're like, oh, okay, then let's do it.
Well, correct. But listen, this morning before I got on a call with you, I was probably on my 6th meeting to try and get a larger plasma for TBI study done there's a point of care test now that has 2 biomarkers for TBI. So imagine you're a patient who's 3 hours away from a trauma center, hit their head, you're on a blood thinner. Imagine there was a test where you could do on site that will tell you, does this patient have a bleed or not? Wonderful, right? But no one's going to use this unless it's been proven. So there's already a bunch of data on this thing, but now I am trying to take that point of care test and bring it into my plasma for TBI study. So what did I do? I brought a group of stakeholders. I brought the expert, Dr. Papa from Orlando. She's been on my calls twice now. I got all the stakeholders from the trauma center, 2 trauma surgeons, the entire biostatistician team. We had that call yesterday, did some follow-up today, and now we're going to get an IRB done. We're going to get, and then with John Holcomb, we're going to do a large randomized control trial for plasma for TBI. So we launched our plasma for TBI in December of 2024, a year ago. It took 6 months to even get that protocol going, but now it's been so successful that now we have Dr. Holcomb coming to us and saying, we want to do a randomized control trial. So it's, if you're in this business, everything takes years, whether it's pediatric readiness, high performance CPR, antibiotics for sepsis, even something as simple as ketamine for seizures.
Yeah.
You can't just come in and say, we're doing ketamine for seizures and here's a new protocol. You can't do that, right? You have to do it. And if you're in a statewide protocol scenario, well, you have to make your way up to the state and do some convincing up there. And it's the same process. It's just on a different level. So,
Yeah.
it's really, it's not something I made up. It's just something that I kind of figured out over time, that there is a playbook for making meaningful change in healthcare that's different than meaningful care in a regular business where you're selling subs, where you have to get your marketing plan better or your SEO, or you have to make more TikToks on sandwiches, right? This is very different than that.
Yeah.
So, but it's more fun, I think.
Yeah. So I want to be respectful of your time. So just really quickly before we close out, could you give the subtle findings of sepsis for the clinical side of like, what are those things that the hidden signs of sepsis that can be early triggers or early like hair on the back of your neck stand up kind of thing for providers?
Yeah, that's a great question. When you look at the respiratory rate and how kids breathe, there's a very big difference between someone breathing fast because they have a metabolic acidosis and they're trying to compensate, versus someone who has a pneumonia and they're breathing fast because they have airspace disease, right? They have pus in their lungs. So when you think of a diabetic, a DKA patient, and how they're breathing and their Kussmaul breathing, so sepsis gives you a ventilation difference that would be hard to pick up if you're just thinking that the kid's breathing fast because they have a fever, or you can convince yourself that they're breathing fast because they have some runny nose and maybe they have, some respiratory distress. No, if your upper airway obstruction, or if you have an upper airway infection, then you shouldn't be breathing 40 times a minute, right? So on those kids, what do? You put the end-tidal CO2 on them. Boom. Immediately, if they're trying to eliminate more CO2 because they're compensating for the metabolic acidosis and their end-tidal less than 25, that's a subtle, very subtle sign, okay? Obviously, the tachycardia is the hardest one because we could all make kids tachycardic just by our presence, right? So that's a more difficult one. The trick I would say, like I mentioned earlier, is put the leads on if you're able to, walk away, okay? And you should see the tachycardia of fear go away once you leave. And so that for me was a go-to for a long time. And the third one, which is hard too, is the mental status. And if you're looking at a kid long enough and intently enough, you could start to see them kind of like they're kind of going through this kind of like like an in and out period of, are they with the program or not? Because if a kid sees you, if the kid's old enough and they recognize that you're a stranger, stranger danger, then they ought to be like watching you, like, what's this guy doing here? Like, I don't know who this person is. If all of a sudden that kid has no care, and then now they're just more sleepy and floppy, and their legs are turned off to the side, and so there's an altered mental meter that you have to have in your head that's age specific, right? Whereas if it's a teenager versus a 5-year-old versus a 6-month-old, what does altered mental status mean? And the best thing to do is to ask the family, right? Because the mom knows 1,000 more times than you do about the mental status of their kid. What we tend to do, and I did this for many years horribly, is I would ignore what the mom said. Because like the mom said, I swear to God, we're at the house and he turned blue around the lips, and yeah. It looks pink to me. It looks perfectly fine to me. When in reality, that's exactly what happened. So listening to the family, spending time in the room with the parents, not examining, not just talking, and just getting a sense of this child is something that you just have to make practice of. If you're in the back of the truck or you're on a helicopter, it's a little harder to do. And I remember very specifically in Pittsburgh, I missed a kid who was septic because we were going to pick up a kid from the outlying hospital, bring him back to Children's, and the kid was septic the entire time. But the tachycardia I attributed to, we're moving along the highway at 60 miles an hour. There's a lot of noise, and we were trying to get a blood pressure. The blood pressure, we could never get one. I wonder why. How bad, very bad. So now I teach people just how to get a palpable blood pressure. A lot of people don't even do that. Where I just say, all I want is to get is a systolic, and to see if the kid's, if I'm getting a palp of 80 or 70, then I take that more seriously than trying to get an NIBP, which is always, it keeps alarming on me because it's not picking up anything.
Yeah.
So it does take another level of clinical acumen and know-how, but that just takes time and just kind of being present. Being present, listening to the mother, looking at the kid will work, will help quite a bit, I think, in your clinical practice.
Yeah, that is great information that hopefully people will put into their practice. And so that really wraps up today's episode of Reducing the Pucker Factor, presented by the Blakery Content. And obviously, huge thank you to Dr. Peter Antevy for sharing his insight, his passion, and his relentless dedication to improving pediatric care in the pre-hospital world. And if today's conversation sparked something for you, or make sure you follow, subscribe, and share this episode with the crews that need it. Remember, confidence isn't an accident. It's preparation, it's repetition, and readiness. And until next time, stay curious, stay prepared, and keep reducing that pucker factor. And Dr. Antevy, one last chance. I want to give you any parting words or words of wisdom, any last thing that you want to say before we sign off.
I'm just very honored that I'm your first guest. I feel like I spoke a lot. I hope I didn't bore the people, but I so much respect what you do, and I think that you just have a way about you, and you're a great educator, and I'm a huge fan. And I hope I get to come back one day and we can talk about more of these softer skills that we talked about today, which is fascinating.
the crew's on the move. Lights up, crew locked in, yeah, we know what to do. Their hearts beating fast in the back of the rig, but we don't panic, nah, we're dialed in big. Scene's chaotic, kids sick, but we're right on track. We breathe deep, lean in, bring the calm right back. We're reducing the pucker factor, turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop, yeah. We're the Blakery Content crew, showing what the pros can do. Turn the fear into calm under pressure, pucker factor, gone forever. Pucker factor, gone forever. Yeah. Got skills, got data, got a plan that hits. Got the airway game strong and the trauma kids. Yeah, from scene to scene, we're raising the bar. EMS super nerds, yeah, that's who we are. Hey! For the medics in the front line, let's go. For the flight teams on the lifeline, let's go. For the ones who running faster, we're reducing the pucker factor. We're reducing the pucker factor, turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop, yeah! We're the Blakery Content crew, leading what the pros now do. Turning fear into calm under pressure, pucker factor, gone forever. Pucker factor, gone forever. Gone forever.